everyone, I'm Dr. Renee Mehrra. Thank you for joining Zoom with Renee. Today my guest is Orthopedic Surgeon Dr. Avinash Jadhav. Thank you so much for joining Dr. Jadhav today. Dr. Jadhav is a fellow of the American Academy of Orthopedic Surgeons as well as fellow of Royal College of Surgeons. He is specializing in robotic knee and hip joint replacement surgery. And it's a pleasure to talk to you. We've been trying to get this interview for a long time because of your schedule. It's very tough, but I'm so happy that today we are here and you're going to share with our viewers a lot of videos on knee and hip replacement surgery. So this is an important topic today. I know you have over 20 plus years of experience in orthopedics and you performed over 5,000 knee and hip joint replacement surgeries, and robotic for the last few years, over 300 surgeries. Tell us how the robotic knee and hip joint replacement surgery excels over the traditional manual surgeries.
Pleasure to join this interview. Let me start by explaining what is joint replacement first. And if you want to understand that, you should first understand what is arthritis. And if you want arthritis, you should understand first how your joints function and what happens in arthritis. In your joints, there's a cushion which covers the bone ends, and that's called as articular cartilage. So if you, for example, just rub your hands for a few minutes like this, the skin will start hurting. But we walk on our hips and knees whole our life, 50 years, 70 years, 100 years, and they still don't hurt. There's a reason for that. Don't hurt in the early years, at least. And the reason for that, these bone ends which rub on each other, they are not in contact. They're separated by a cushion which covers the bone ends. And this cushion has no nerves in it. And that's why you cannot feel the pain. So as long as this cushion is intact, you don't feel pain when you're walking, running, jumping, or doing whatever, even if the bones are rubbing against each other in the joint.
The articular cartilage that's there, that's like a protective cushion, and it starts to wear and tear when you're in 50s and your 60s.
Precisely. It's just like the tire of your car. If you drive the car for 50,000 miles, the treads go down, the tires wear out. The same thing happens with this cushion. You walk on it for 50 years, the tread, I call it, it goes down, the cushion starts to wear out. And although the good thing is it doesn't have nerves, it also doesn't have blood supply, and that's why it doesn't heal. So once it's gone forever. And that's why the bone ends become bare and they start rubbing on each other, and that's what we call as arthritis. That's what gives you the pain. So the solution to this is cover the bone ends with, again, something new, something different, something artificial or synthetic. And that's what is joint replacement. So joint replacement is nothing but we are replacing the cushion, the protective cushion at the bone ends in the joint. Now, when you go to replace your tire, once it's worn out, you go to replace the tire. The person also does a wheel balancing, right? And the reason for that is if you don't do the wheel balancing, then the cushion or the tire will wear out again very fast because there'll be uneven wear on it. The same thing is true about this protective cushion in our knees. So the limbs have to be aligned correctly, like the wheels of the car have to be aligned correctly. And traditionally, this was done just manually, by looking at it from a distance and making sure the limb looks reasonably straight. But would you go to a mechanic who just does your wheel alignment, looking at it rather than putting on a computer and measuring it? No, you won't. Nowadays, when you go to a garage, they give you precise measurements about the wheel alignment. Make sure it shows 0, 0 on both sides, or maybe a -half and +half, that kind of accuracy you get. If we are getting that kind of accuracy in just aligning our wheels, why don't we get that accuracy when we are aligning our legs? And that's how the robotic replacement, or even before that, a computer navigated surgery came into existence. We decided that instead of doing it manually, the alignment, we should get more precision. And the importance of this is the knee replacement surgeries traditionally have about 80% satisfaction rate, and we want to increase it. We want to give a satisfactory knee replacement to each and every patient. We are striving to get to 100%. And how we can do that? By doing everything perfect, precise, accurate, cuts, and replacement. There are three important things for a long-term success of a joint replacement. One is this alignment I talked about, that has to be precise. then the size of the implant that you put in, they should be of the precise size. They cannot be too large or too small. And finally, these implants have to be put in correct position on the bones so that everything looks perfect and straight and it will last you forever. And this is what the robot helps you to do. What we do is we do a CT scan first, feed it to the computer, get the perfect alignment measured on the computer. Actually, we make the cuts on the computer. These are like virtual cuts. So we actually perform a virtual surgery. We find the difference, the size of the implants, put it on those cut bones,
So
and
you do
perform a
like
virtual
you
surgery.
do like a surgical plan before that you actually do the surgery, and you do those vertical cuts on
Correct,
the computer.
correct,
Okay.
correct. Correct. At least a couple of weeks before actually doing the surgery, patient goes to a radiology department, gets a special CT scan done. The data is fed to the computer. We decide the alignment, we decide the precise cuts and the precise size of the implants that we're going to put in. We actually put it through the range of movement to make sure they're all moving well. And when we like it, we fine tune it and lock it in. And then we put this data into the robot and take the help of the robot to make the cuts absolutely precisely. Because if you do it manually, there's an element of human error. You cannot really make the cut within 1 or 2 degrees of error, and robotic arm eliminates this chance of error so that we can give perfect result to each and every patient every single time, and not just 80% of the times.
Yeah. So you're avoiding the human error, and it's more accurate, more precise. It's pinpoint precision, and I'm sure it's minimally invasive, or it's less invasive than the regular traditional surgery.
You bring out a very important point. Yes, I mean, besides this precision cuts, these are the other benefits you can get because everything is planned on the computer before. Traditionally we have to expose the bones to a bigger cut, see it all. Now we don't have to see that much because all the cuts are already pre-decided with the help of a CT on the computer. So we can cut through a small part of the skin, small incision, look through that and only make the cuts that are necessary. So there's less tissue damage. And so there's a faster recovery.
Right, right. Tell us, who qualifies for robotic knee and hip joint replacement surgery? Is it across the board, or there are special categories that you decide, okay, this one will go for robotic surgery?
For a primary joint replacement, it's practically across the board. Everyone can qualify, but not for revision joint replacement. The robotic surgery is not developed for revision. And the simple reason is when we do the robotic hip and knee replacement surgery, we are really hoping that the surgery done first time would last forever. And that's what is happening. And that's why, unless, of course, there's an infection or some other problem, you won't have to revise it. And so as long as it's a primary, that means first time surgery being done for a knee or hip replacement, you can have it done in the robotic way.
Now, you have a video that shows the functions of the robot, how it works, and tell us, and it talks about probably the alignment and the cut and the size of the implant.
Yes, I will show you now that video where I'll take you right in the operating room. I'm about to do a knee replacement surgery. I'll explain to you how the robot looks, the robotic arm, and how the robot is going to help us. I'll show you the CT scans that are done and how we manipulate that, how we decide the cut, how we decide the implant size, how we decide the alignment in which we are going to put the implants in. And then I will also do a live surgical demonstration, at least some key steps of it.
Hi, this is Dr. Jadhav. I'm going to today explain to you what is a robotic total knee replacement and why it is better than the conventional knee replacement. So we are all set up here to do a knee replacement. I'll explain you and then I'll show you the live demo also. In doing the joint replacement, the long-term survival depends on 3 important things. Number 1 is choosing the correct size of the implant, not too big, not too small. Number 2, making the precise cuts. And number 3, putting the implants in the correct position, the alignment of the implants. And the Mako robot helps you to achieve all these 3 things. This is the Mako robot, how it looks. And this is the robotic arm, and you can see the saw connected to it. And this is what helps you to make those precise cuts. But before the Mako robot can do this, we need to feed in the information to the Mako robot. And for that, we get a CT scan done on the patient, and I'll show you on the computer screen the CT scan and how we work with it. We do first, and I'll show you, this is the CT scan, and you can see different cuts here of the CT. And we use this CT scan images to make a 3D image, and which you can rotate it the way you want to look around. You can see the osteophytes in this and do whatever you need to do. And then you try to put an implant on it like this, and you can choose what's the best size of the implant. And here you can change the implants. Here you can choose the femur. If you think this is too small, you can go bigger like this, or if you want to go smaller, you can go like this. And then tibia also, let me go back to, that fits the best. Same way you can adjust the tibia and the thickness of the polyethylene in between. And then you can decide what cuts you want to make. So this shows the cuts superimposed on the implant, and if I take the implants out and do the cuts, that's how the cuts look. And the Maker robot will show you the precise cuts, how to do it. So we've already done planning for this patient. So let me get back to this, or maybe this, the implants, and then this can show you how much gaps are there. And you can virtually do a trial surgery on the computer. Make sure that everything works well, it bends well, it's stable, and when you like the numbers and the cuts, you just log them in and then feed it to the robot. And doing surgery with the robot would help you to make those precise cuts. Let's do the surgery.
All right. Now we're going to go back to the operating room where Dr. Jadhav is going to show us a live surgery of knee replacement.
All ready to go and do a knee replacement. So the key step in this is we have to register the patient's anatomy to the CT scan seen on the computer. So we're going to do the knee replacement. We are all ready to go, and here we go. So here I'm first going to, those are the trackers, those black things you're seeing, those are the trackers, and they communicate with the trackers attached to the computer, and that's how the computer knows where the bones are in the, so this is the tracker attached to the computer. Now in the next surgery, so those trackers are communicating with the tracker on the computer. I'm moving the leg around, and so that the computer finds out where the hip is located. And then I show where the malleoli, that is the ankle, is located. And we need the computer to know where the ankle is and where the hip is, so that we can align the knee right in the middle of it in the same line that connects the center of the hip to the center of the ankle. So those trackers are showing now to the computer the medial malleoli is located. These are the points on the lower end of the femur, the thigh bone
So
you're
you mapped
seeing.
out all those
And
points.
now,
This is all the points that are mapped out over here. So what is these points indicate?
correct. So the computer is asking, we have to tell the computer, or it is showing the white dots and the blue dots that are on the CT model that is fed to the computer. And I have to point with the tracker that I showed you, each of these points on the patient's real bone, so that the patient bone correlates with the CT scan model in the computer. It's more or less like a GPS. When you're driving your car, you are on the road at a specific point, and the map on the GPS screen knows where that point is. And that all correlation has already been done. And the satellite is helping to show you where your car is on the map by looking at your car on the road. The same thing is happening here. Those trackers I showed you, those are like satellites. This is the GPS map, and the patient's body or the bone itself is like the road on which I'm driving my car, which is like this, my surgical instruments. So this is a good analogy to understand this. So these are the points. Now I'm going to show, to register it, each point, these blue points at a time, and then the white points to the computer, so that the 2 points can be correlated to each other. So with this pointer or the tracker, which works as a satellite, I'm showing each of the points. And as I show it onto the computer here, those are registered. So here's a closer view. So those points disappear each time I point. So these are the, now the computer wants me to show this point. So I pointed that on the patient's anatomy. So it disappeared. So they keep disappearing.
Very interesting, yeah.
And then we get this additional 4 sets of points. And then I show that to the computer where these points are located on the patient body, and they disappear. So this is how the computer knows what correlates with these points onto the patient's body.
So when you're doing the manual surgery, you'll have to put those points yourself.
No, in the manual, it's all very crude way to do it. We just look at it, we'll ballpark it. We just go look at it. How does it look? Oh, this looks like a reasonably good cut, and we just go for it. We don't go through the trouble of mapping these like this.
I see.
With this tracker or the satellite, I'm showing to the computer where the points on the tibia are located, the points that the computer is asking. So look here. Now, this is the upper end of the tibia, and it's asking me to show these 4 blue points. So the bigger blue circle is the one it's asking me to show. As soon as I show it that point, it disappears and it moves to the next blue point.
This is so interesting.
The CT scan then asks you to confirm it. So now here, even bigger blue dots you're seeing. So I have to touch those blue dots, and now it's the other way around. When I touch the correct spot, the computer turns it white. So this is like a cross-checking. It's examination and cross-examination. So we're absolutely doubly sure that the computer CT scan model correlates to the patient's body. So this is how. So the robot, the saw is loaded up into the robotic arm, and I'm cutting. But while cutting, I'm actually going to look at the computer screen, and the computer screen is going to show me the part of the bone to be cut in a gray area, in a green area. So you see here, it is showing my saw blade, and it's showing that green zone. That is the bone that I need to remove.
I see.
So I just guide the robotic saw to that bone, and as it's cut, the green zone in this disappears.
It's here right now, so probably it'll disappear once you have cut it.
So it disappeared on this side, and you see there's a green zone on the other side, so we will come and cut that bone also. You will also see that there's a green line all around it. It's like a rectangle. So that's the safe zone. So it's the boundary. So one of the biggest advantage of robot is it doesn't let the saw work beyond these boundaries.
Right.
And that's how it protects the soft tissues. So there's no chance of making any human error to cut soft tissue or a blood vessel or a nerve or a ligament that you don't want to cut. It will only cut the bone. If the saw blade goes beyond these green lines, then they'll turn red and the saw blade will actually stop.
But you need to program it in a way that...
Correct. It's all programmed. All that work is done before we even start the surgery.
Yeah.
Not only it shows which bone to cut, but it also shows how deep it to cut. Okay. So if you cut a little too deep, then it'll turn red. Now, a little bit of red is okay, but and I actually, in this case, there will be a little bit of red, and that's why I'm explaining you how, and it's on purpose so that you understand how the robot helps you. So now we're going to cut. See that red boundary? So I tried to take the saw blade beyond that green boundary, and there was a red boundary up here. So that's a yellow boundary, means you're okay to go. And now it turns green, means we're ready to go. This almost feels like you're mowing the grass. As you move the saw, that green part disappears. And see that red part now? So I went a little bit deeper there. Actually, this part is not important, this particular area of the bone, so I could do it for the demonstration purposes. And that part of the bone on the CT scan turned red. Robotic surgery.
So this is the CT scan we do first, and as you can see here, that's a CT scan. We feed that to the computer, make various measurements.
Let's look now at the hip joint
a
replacement surgery.
Reconstruction model out of it, like this. The model can be turned around or moved around, and then we can put an implant on top of it, like this. And this is the cup situated, and we can change the size of the implant on the computer. So I'm putting a bigger one now, like that, or I can go smaller, like this, and then I can choose the correct size. Once we have the correct size, we put it in the correct position. So we can tweak the position by moving the implant sideways, up, down, and also turning it in like that. So once we have the correct position, and we do the same thing for the femur also, on the femoral side, and so we've got the implant, we've chosen the correct size, we've chosen the absolutely accurate alignment, and now we feed this information to the Maker robot to make it so that it can make the precise bone cuts in predetermined thing. So basically what we are doing is performing the surgery, a virtual surgery on the computer to make sure that we get the best result, and then feed that to the robot so that we can duplicate it accurately without any human errors. I will give you now a live demonstration of the surgery. Thank you.
So this is showing the socket in the hip joint, and this is the inside of the socket that has been painted blue onto the computer screen. And the computer is asking me again, as we register different points on the knee, to tell the computer where the patient's bone exactly is in relation to the CT scan images on the computer. The same thing we are going to do here. Now, because this is a cup, we're basically going to paint this area. So that blue area, I'm going to paint that into the patient's body, as you can see here. Mm-hmm. So I'm using that tracker again and paint, showing the computer where this blue inside of the socket is located. And we need 16 points to do that. If you see the numbers on the top right-hand corner, they were changing. So now we are at the 11. It's asking me to show it on 11 different points. So once that is done, then the computer will ask me to show the outside of that socket. So here you'll see this outside of the socket is now painted blue. And with this tracker, I'm going to show it where that outside of the socket is located.
So in this surgery, I don't see those white and blue dots on the computer.
Yeah, for the hip, it's a little different. You know, you don't actually have to have different dots because it's a circle, a spherical surface, or hemispherical surface. We have to paint it kind of with the tracker. So we just need to go through 16 dots, okay? And as long as those dots, that area is covered or painted well, the computer accepts it. And then it asks the same thing, like those bigger blue dots, which are bursting the bubbles, I said, you know, we burst those. This area, it shows that this green area is the one that needs to be reamed out. It's not a flat cut with a saw like we did in the knee.
You have a little white part in this green area, and there's a little blue. What does that signify?
So the blue is the axis of this. As I said, it's a hemispherical. So blue is the axis of that hemisphere. Okay. So when I'm reaming it, the reamer's axis has to be along this blue line. This white area, there's already a defect in the bone. So we don't need to ream there. We're just going to ream this. And the reamer is a hemispherical thing. So these defects are deeper. So it's not going to touch those white areas anyway. Okay. So it's just going to touch this. And as we ream it out, you will see this circle, green circle, shrinking. So you see the border is over here and it'll shrink, go down. If we go a little too deep, then it'll just turn a little bit red. And then we have to ream it completely so that this whole thing turns white. Okay? So that I'm reaming and you'll watch the edge of it.
Yeah.
See how it shrinks? So that's how it, and if you ream too much, look here, the red line appearing. So that means I'm reaming, there's too much bone removed here, just a little too much. And we're talking about like hundredth of a fraction of a millimeter. So that's not, and this shows you exactly how deep you're reaming, how up you're reaming, how medial you're reaming. Mm-hmm. So I'm not going to take you through the whole thing because it takes a little while to ream through, but you got the concept. But basically,
what's the duration
of the
procedure? How long does it take?
Yeah. The hip, typically the surgery takes about 1 hour, you know, starting from start to scratch. This robotic part probably is about 15-20 minutes of it. The rest of it is really opening, you know, exposing the bones and also closing up. So 20 minutes at the most, half an hour is what we need the robot to do the cuts
For
for.
1 hour.
But most of this information is what takes more time is fed into the computer previously, prior. And then we have the plan already ready and we just execute it and take the help of the robot to execute it with precision so that there's no human error in it.
Right. And then the knee surgery, knee joint replacement, how long does that take? Also an hour?
About the same thing, about the
Yeah. Okay.
same. But yeah, both surgeries take about an hour. And the hip surgery can be done in the past in the United States. They were mostly done through what is called as the posterior approach, and then we know that it is better to do it through anterior approach. That posterior means from behind, and anterior means from front, and so that's what I do basically. And this robotic technique can be used either way, from posterior approach, anterior approach, or from the side also. So I sometimes in a bigger patients I do it from the side, but still dislocate this hip in the front, because once it's located back in place, it's more stable. The advantage of going through anterior approach is that we don't have to cut muscle. We just separate the muscles and go to the bone and do it.
So it's less invasive, obviously. Yeah. And when you're talking about the regular traditional way of doing surgery, is that longer in duration?
Actually, to be honest, if you take all the time that is put in doing a robotic surgery, that takes actually a longer time. The reason, because there's a lot of planning involved in it. We have to get a CT scan done first. We have to study the CT scan, make this 3D model out of the 3D CT scan. Then on the CT scan, we actually perform the virtual surgery. We choose the correct implant size, decide what position those implants should go in, and decide how the bone should be cut to, so that the implants will go in the correct position. And when we actually assemble it all and make sure, go through a trial on the computer, so that virtual surgery. So there's a lot of time spent before the surgery. And then actually in the operative theater, you have to get the robot ready, and that's additional step. So it adds a few minutes, maybe 5, 10, maybe at the most 15 minutes to the surgery.
And went to the operating room with Dr. Avinash Jadhav. Really interesting facets that I saw today. Tell us, we know that when we're doing robotic knee and hip joint replacement surgery, it's very accurate, it's precise. So does it really enhance and increase the life of the joint and its smoothness, as opposed to the regular traditional surgeries that been performed before?
Of course. I mean, as I said, I'll go back to the example I gave you earlier. If you put on a new tire on the wheel that is malaligned or misaligned, then the tire is going to wear out faster. It's exactly the same thing. If you put the new artificial cushion on this joint, that is, do your joint replacement without aligning the bones correctly, it's going to wear out faster. And because with the help of robot, we do it precision alignment, accurate alignment, it will last longer. It does last longer. Not only that, there are several other benefits of the robotic surgery also.
I see. What are the some of the exercises, post-operative exercises that a patient should be going for, and is it like after a few days they go for the rehab?
After the post-operative exercises are no different than the conventional hip surgery and this surgery. The advantage of doing robotic, because your positioning of the implants is so precise, the chance of it coming out or dislocating is minimal, next to nil, really. And so you can start the exercises sooner, you can be more aggressive about it, so the recovery is faster. Another advantage, as I said, about robotic surgery is we don't cut unnecessary muscles and ligaments, because on the CT scan, we already know where to cut. So the incision is smaller, the exposure is smaller, and there's less damage to the surrounding soft tissue. So they are intact. So they don't need to heal because they've not been damaged. So the healing is faster, the post-op recovery is faster. And what that means is the patient can do the post-op exercises faster and get back on his feet faster, get back to his normal life faster.
So they go with the assistive device, could be a walker or a cane.
Usually most patients, nowadays we are trying to do them as a same day case. So the surgery is done in the morning, and by evening the patients are discharged. Now most of these patients tend to be older, above 60, 70, or sometimes even 80 years old. or plus, and that's why we like to keep them, if their medical condition is not very well, to keep them in the hospital at least one night, make sure that their blood pressure is stable, they're taking their blood thinners okay, all the medicines are back, and we discharge them the next day, so within say 24 hours. And at that time we usually give them a walker, so the same day of surgery they will walk with the physical therapist with the help of a walker, putting full weight on this implant, just to give them a feeling that nothing has really changed. And the physical therapy will go with them through this walking exercise. Again, the next day, they will also try to get them to do stairs if they have stairs at their home. And when they are comfortable, we discharge them. We advise them to use a walker for a day or two, simply because to help with the balance, simply for safety reasons. And then very fast they can move, discard the walker, move on to a crutches, maybe a single crutch, maybe a cane. And most of the patients, when they come to see me 2 weeks after the surgery in my office, they are walking without any walking aid, full weight bearing, and virtually without any pain.
Any downside of robotic surgery?
Not really. I mean, the only downside, if there is any, is that it takes more time for the surgeons to plan. It is really no downside for the patient at all. The surgeon has to spend more time in it as far as planning is concerned. Maybe there's little more time spent in the operating room because of the setup of the robot. You have to do a CT scan beforehand. But again, all this happens with no extra cost to the patient. The cost is the same. The complications are actually dramatically reduced, and the success rate is massively increased. As I said before, the total knee replacement satisfaction rate done by conventional method is about 80%. We are aiming to get to almost 99% with robotic knee replacement surgery, because of the precision that we can repeat every single time in every single patient without fail.
So success rate 99%, that is amazing. Now
It can get up to that, yes.
Yes, you're a handful of doctors in Florida. I know that you practice in Citrus Hills and Hernando County. How many other orthopedics are there that are performing robotic knee and hip replacement surgery?
In the county, a couple of counties I work, there isn't anybody else besides me currently, to my knowledge, using robotic hip and knee surgery. And there are really only a handful of surgeons currently in the state of Florida. This is a technology of the future. The reason of its slow growth has been mainly the investment. The robot itself cost about $1 million to $2 million. So the hospital has to invest in it. And in return, the hospital really doesn't get any extra money from the insurance companies, because the surgeons as well as the hospital gets paid the same amount of money. So there's some reluctance in investing in this. There's also reluctance on the surgeon's point of view to invest their time in it, not only the time to do the extra training, but also the time required in planning each of the surgery beforehand, as well as the setup. If you were doing previously 10 joint replacements in a day, maybe you'll only be able to do 6 or 7 if you're doing robotic joint replacements. So those are the reasons I think it is not catching up fast, but it's definitely going to catch up, because patients are demanding it, patients are asking for it, and we owe to them to give them better results, more guarantee of a successful result every single time. And so it is definitely a technology of the future, and will catch up in future as time goes on.
So this is the technology of the future. So what are the futuristic trends that you envisage in knee and hip joint replacement surgery when we're doing through robotics?
The materials will improve. Actually, that has been one of the most important changes that have happened in the last couple of decades, that we have better plastics available, better materials available that will allow for better bone growth.
You say the metal and plastic can wear off after some years?
Correct. The plastic is the part which wears off. Really, the metal is hard enough. And that's why this robotic, as I said, is important, because if we align the joints correctly, then the plastic will last longer. It won't wear off that fast. At least 20 years, if not 20, probably 30, 40 years. Basically, we are doing these surgeries in 60, 70 years old patient. So we are really aiming that once we do the surgery, they are pain-free the rest of their life.
Right. Well, you know, you have performed over 300 robotic surgeries in the last few years of knee and hip joint replacement. It must be very gratifying for you. And been the success rate?
Indeed.
What has been the success rate for all these surgeries?
It's above 95% success rate.
Wow, that's wonderful. and you want to continue doing this. I believe you also give a lot of workshops on this.
Yes, I do participate. There are more and more young surgeons who are getting interested in the robotic joint replacement surgeries, and I participate in training them in the cadaver labs. It is really a gratifying experience.
Well, thank you very much, Dr. Avinash Jadhav, specializing in robotic knee and hip joint replacement surgeries, and wish you all the very best in this futuristic trend.
Thank you very much. Thank you to all the community who's watching this video, and wish you all a very happy 2023. Thank you.
Happy 2023. Thank you, and I'm Dr. Renee Mehrra. Stay healthy, stay positive.